as well when you talk about evidence-based medicine and evidence-based practice, and that's big data can solve this problem, because from your data, the knowledge hidden inside your data can help you to extract the knowledge and build the evidence-based medicine and practice. Are you in the Ministry of Health aware of this important big data investment? Are you investing? Are you doing something about it? As all industries and big companies in the world? Thank you.
Well, I believe that they are familiar with it as far as...
Next presentation.
Yes, that's the next presentation. So I'll leave that part of it. But as far as the data, our big issue with any data gathering type of system, and this has been generally proven statistically for many, many years, is that when you initially implement any kind of an application, it doesn't matter how complex or how simple, even the simple ones are problematic, is that we set our expectations too high. Statistically speaking, Hessen should only have brought forth the first year from the people who had Hessen for 1 year, 6% of the data. Because it's a new technology, there's new methods, brand new training. This is not something that you do as part of your job. So to suddenly start to work in an application, it's not simple, because a lot of times you've got a manual, even though you've had 1 week's worth of training. You have a manual open and you're trying to find where you need to go to do the data entry, and it becomes problematic. So we need to revisit every place we've gone, do follow-up training, follow-up advice. The second year, we're hoping, praying for 60%. If we get 40, I'm happy. By the third year, you better be getting into the 80 to 90 percentile range, or there's something wrong. And this is how we kill projects. Afanet in Africa was built with the idea that this was an incredible epidemiological application that provides infectious disease reporting, and all countries in Africa were invited. That was 2 years ago. They just killed it last week because nobody was using it. It's like, if you build it, they won't come. This is one of those areas where you've got to understand your target audience. You've got to understand the infrastructure. You've got to, and it's way beyond that. The politics locally here is huge, because there are cases where people are actually angry at having to do something on a computer. So to actually have the staff that we've had with Hessen, and we've got some brilliant people, they've gone a long way towards the implementation of the application. They know they have a lot farther to go, but ideally, this is what we need to make sure that the expectations of senior management is set a certain way. One of the things about an application like Hessen, like NHSN, is you typically don't want to throw everything out at one time. You want to have a targeted solution. And so just do VAPS, or just do CLABSIs, just do tuberculosis, or just do STIs, and focus on a staff that starts at the headquarters and goes to the region and goes to the sector and all the way down. And if you do this, then you can actually have a better assessment of what you're doing. So you're doing smaller chunks. We started with the idea that we would do everything and then assess. And I think that's what they're going through right now, is some of that assessment.
Thank you.
Okay.
Yeah, the mic is there.
Ma'am?
Thank you.
I hear it.
Good morning. I'm Dr. Nof Khankar, Infection Control Coordinator in King Saud Medical City and Public Health Informatics student. Actually, doctor, I witnessed the birth of Hassan in King Saud Medical City. So I'm a little bit curious if we will be able to use Hassan as a way to be a paperless in the infection control coordinator. Will be Hassan and at a certain point a tool to achieve that?
Well, Hassan's intention, I believe, and I can be corrected because I've got one of the project managers here, is to do the MOH hospital system and public health clinics first, and then move to the other hospitals. Now, they may, based on requests from different groups, alter that or provide something to them, but you'll have to talk to them about whether there's the capacity to add someone else. I think part of our problem with Hassan is just in terms of organization is that we've got a plan, we've got the resources, we don't have much else. So to add more to that, we would add it to the end, not in the middle or at the side. Sir?
Assalamu alaikum. I'm Dr. Laik Zaman. I'm coming from Majma University here for this talk. Thank you very much. It was very elaborate, I must say, and very enlightening as well. As a teacher for the students, I was wondering, do I have access as public to some data or maybe some GIS that I could show to the students as an example of what's going on in Saudi Arabia in this direction? Thank you.
Well, you said a couple of things there. As far as data is concerned, data belongs to the patient. Privacy is a worldwide concept. But anonymized data is something that you can certainly request and get from the Ministry of Health. We've got a research coordinator, Malik Al-Mesri, I think. Is our research coordinator, and requests can go to her to get that information. I may be able to give you contact information later, and that usually goes up to, I don't know if it goes all the way to the minister. It may only go to Dr. Ziad Mimish. But you said GIS, and there's an interesting concept with GIS that a lot of people don't necessarily understand. We have no address system here. So in the U.S., BioSense was based on zip code. Zip code could be a very small geographical area. It could be a very large one. So it wasn't the best method, but it was the only one we could do based on privacy. We started to think about using GIS, but the majority of our people do not go to clinics. They go to hospitals. And so with a GIS system, it looks like everybody's getting sick at the hospital, not at home, not where they go. We used GIS during Hajj the last 3 years. And what we did is we had teams of medical personnel that would move, or they'd have a tent somewhere. And so when they actually had a complaint, they press a button on their iPhone, and in one of these forms that we have up here, it institutes the GIS location, so you know within a meter that this is where this person got sick. And so if you see a lot of people getting sick, things don't necessarily happen that quickly, but you can understand the approximation of where things happen and how they move out. Surveillance is kind of tricky when it comes to alerting. BioSense, one of the largest databases in the world, I think I told you, never alerted anything before CNN or Al Jazeera or MSNBC or someone else. So what we did was we created a software application that does voice recognition. And so it happens when you're in the field and you're a CNN reporter, you're talking back and forth to the person before you actually do a broadcast. And you say, well, it looks like I've got Ebola. There's a huge Ebola outbreak here. And so that goes to the CDC, as a voice recognition with the word Ebola is one of those words that are identified, and then our BIC, our Business Intelligence Committee, rolls the tape back and listens to it and says, oh, they're in Kenya, we've got a CDC implementation there, they call and they go and they check. That's about as fast as it gets, because it's usually somebody on the phone calling somebody saying, wow, this person's bleeding out at the eyes and nose and he's got some sort of hemorrhagic. And so this is unfortunate but true. So most of our surveillance is more for statistical analysis and benchmarking and this sort of thing. We've had needle stick opportunities because we've had needle stick at MOH for 3 years. So when they do the reporting of the sharps, we get this information, and it turns out that there's certain ampules or different kinds of glass that break all the time. And we saw that over 25 hospitals, and so we stopped buying that particular brand because it broke too easily. It was, the value of it was too low. Does that answer your question? All right.
Hello, this is Shafaq Bukhari. I'm a faculty member here in College of Medicine. I just need, because you have mentioned you have been a trainer in biostatistic and also in evidence-based medicine. We are interested if we can just have some training from your institution. Is there any specific courses where we can go for or we can enroll and learn from your expertise in this particular aspect?
Well, this is the kind of thing that happens ad hoc. I went to Prince Sultan Military Medical City to visit a friend, and then they asked me to teach there. And I asked permission, I got permission, and as long as I stayed in the kingdom, I could do pretty much what I want in terms of training. I'm hoping, the boss isn't here, so... I'm hoping that within the next 2 weeks, I'll be finding out that I will become, I'm not really sure what you would call me. Am I a professor or I may be working on the medical informatics team here if things work out. And then I'll do some teaching. I will offer, if I come here, I'll offer courses in biostatistics, SPSS, SAS, and those three at least once a quarter, 5-day classes. I have the privilege of, from IBM, from SAS, as well as other places, to be given their material, and I can give licenses for 1 year for free to my students. So, and I've never charged anything, so I'm not sure if there is a charge for those things. Okay.
There is a center called Saudi and Gulf Center for Evidence-Based Medicine, located at the National Guard Hospital or the University of King Saud bin Abdulaziz for Health Sciences. So they always, from time to time, organize evidence.
I teach at the National Guard too.
Yeah, they organize specifically evidence-based medicine training and a lot of things. If you're interested in this, you're welcome.
Any more questions?
Oh, another question?
Yeah.
Hello, welcome. I'm Yasser Amra. I'm the clinical guideline advisor for the hospital. So I wanted to ask about the National e-health program or project. So you mentioned something about different healthcare institutions that have different, what you call EHR or HI systems. If they buy from one vendor, it will still be difficult. So what about that each different healthcare facility buys from a totally different vendor? And I don't think there is quite a clear plan for integration between these systems. So since it's a national project, I think you plan to outspread outside of the MOH. So what is the solution or your suggestions for this?
Well, ideally, maybe 6 years ago, MOH used to buy everything centrally. There's one purchasing done by MOH. Something happened where it wasn't effective enough, so they allowed the regions to start purchasing on their own. So they established their own vendors, their own, their own contacts. They got their own budget. The critical piece to this is that now, statistically, we can show how bad it is to have multiple vendors providing the same information. And that's one of the things that can be studied from some of the data that we gather. At the same time, if you've got multiple vendors that are selling different products, then you go from the ability to stratify across regions to stratifying across time. So now, if there's one vendor that sells one product, you now have to wait 12 months or 24 months or 36 months to actually evaluate the safety of different vendors' equipment. So. Oh.
It just would like to know, what's your time frame to converting from the manual reporting process, which is going on nowadays, until the electronic ones?
Again, it depends on scaling. MOH, their initial plan was 2 years to go from a manual process by the phone to an electronic one. What they discovered fairly quickly is that moving to electronic was impossible. So they came up with a 5-year e-health strategy. So now your 2 years for Hessen becomes 5 years. Now, if there's problems with that 5-year e-health strategy, then it could be longer to actually do the electronic implementation. So this is why we try to look at both an entry, a middle, and an ending goal for our applications. It used to be that you didn't want to waste your time with the first two because you wanted to put all your resources at the end. The problem is that if that never actually occurs, then you've wasted all of that time. So this is, when they brought me here, they wanted me to come up with solutions that would fit the infrastructure. And so what I did is I went to about 20 hospitals. I went to 10 clinics in Jeddah, in Riyadh, in Jazan, and I looked at their process, I looked at their workflow, I looked at how the data actually goes from the clinic to the sector or the region, from the hospital to the sector or the region. The hospitals are using what they call water inspectors, they call them health inspectors, but their primary function at the hospital is to inspect water, and they're not medically trained. They are just there to inspect the water supply in the hospital. So what they were doing is they were collecting a piece of paper and they're faxing it to somebody. So I went to the region and I looked, and there's a wall of baskets, and there's a fax machine with about 200 pieces of paper still sitting in it. And in that fax machine was reports of measles, was reports of dengue fever. And so what they do is they pull it out of there and they put it in the basket. And then someone gathers that information and types it into an Excel document, and then they email a copy of that to the responsible infectious disease person at the headquarters. This could take a month, even if certain diseases are supposed to be reported in 24 hours. So to them, the process of reporting was done when the hospital diagnosed and faxed it to the region. They're done. That's the 24 hours. We would find out 2 weeks later. And it's still that way today in many places. So what we had to do is we had to look at that workflow and determine that there's a way that we can get them to work now, and there's a way that they can work in maybe 1 or 2 years, and then there's a way that is the end game, which is where we've got a web-based solution that everybody can get onto. The idea behind Hessen is that 38,000 people will be able to log into this one system and either gather information that you have the ability or the rights to see, or enter information based on who you are. Because it's got, well, it's at the back of my head. It's got the ability to do many things. The problem is still people. Our issue with the process is that they, at the hospitals, have determined that for the last 20 years this is what they're doing. We're going in and asking them to do something different. But the idea is that once they start to use these PDF forms, they can't stop. It becomes something that's ingrained in their process. So now I've got a form that's validated. They can't not enter the minimum amount of data. They can't not enter the ID. They can't not enter the gender or the birth date. Because they can't save the form, they can't print the form. We can build this into their form. Now, when they're done with the form, they print it out and they stick it in the patient record, and they give a copy to the health inspector, who then faxes it. But with Hessen, now they just walk over to the computer and enter the same information there. They can actually take the form itself and upload it into Hessen, and Hessen will automatically draw the data into the database if they have that capability. So in the interim, what we're looking to do is to get them at least to start using the computer. We get them to use a form that has validation on it, so they start to understand. At some point, they'll have to log into a system to actually do the upload. So we've got many different things that go into the process of moving them from where they're at, which is, many of them know how to use a computer, but we'll get them involved in entering the information onto a form, then onto a computer form, then onto a web-based form, and we go from there. And so we're teaching people mouse technique. We're teaching people Windows. We have problems because majority of the computers at MOH are still on XP. They stopped supporting XP like 2 weeks ago. So ideally, you've got issues where certain applications have to be at a certain level before you can run others. So the Java machine that's on an XP machine can't be updated anymore because it's no longer supported. And if our application, if our Hessen requires that the Java be at a certain level, then it's not going to work. So we have to provide them with new computers. So there's so many aspects to doing a project of this size. Not just the political, but there's social issues. People want to get paid. They want to get paid extra for doing something that will eventually make their lives easier.
Can I ask a question, please? Thank you.
Oh.
Thank you for your lecture. I'm just concerned about something like related to the safety network. I understand that MOH is not like NHS in the UK. It's not a full 100 representing the whole country. It's only 60%, 65% of our healthcare system is managed by MOH. So based on your experience, when are you going to target the whole country? Like, why didn't we have this network, not like an internal network, rather than it's like a nationwide network? This is number one. Number two, you mentioned about safety content is only related to infection control. But I didn't understand, I didn't hear anything related to medication errors and some, safety parameters like falls or pressure ulcers, etc. These are the main, the sensitive indicators in any hospital. And the third question, I can see that you are starting from the very beginning. I understand in Saudi Arabia we don't have a nationwide HIS system, but we have some hospitals where they have reached to an advanced level, like HEMS level 6, and so why didn't we share information with them? Why didn't we learn from them, as they are experts in our context? as like this is the Saudi Arabian context, which is like different from other contexts in worldwide? Thank you.
Your first question about NHSN, it's open source and it's available to everybody. As far as sharing the data, this is problematic because right now you'd have to work with MOH way above me. I think Dr. Kashem is the principal on what information actually gets shared outside of the ministry. And so the data is there and it's accessible. We have the capacity to do a lot of information that can be anonymized, so you don't know which hospitals they are. The problem still remains is that you'll see the efficacy of infection control at MOH. And if they're not ready to share that, I published something 2 years ago. I didn't mean for it to get published. It was more or less someone asked me to write something up, and I did, and somehow it got published. But what they had started asking me was, we want to understand underreporting. How can we validate that a hospital in their infection control is underreporting? And I said, well, I probably shouldn't name the hospital that's here, but it's one of the top hospitals in the kingdom, okay? I compared its infection rate against Harvard University Medical Center and Johns Hopkins, and it was better. It was lower. And I said, this is a problem because these are the two best hospitals for infection in the world. Yet there's one here that's better. And I know for a fact that it may be one of the best here in the kingdom, but it's not the best by far. So when I wrote this up, I showed this information, and I didn't do it sarcastically. I did it more or less, you see the problem, and it can be either definitions, because they don't understand what a valid infection is. It could be underreporting because we're only getting one department. King Saud Medical City has two different, they have two different infection control departments. One for the ICU and one for everything else. And so I get information from the one, but not from the other. And this is a problem because the majority of the infections that we're interested in are in the ICU, not in the rest of the hospital. So when we went to them and asked them why they were doing this, they told us point blank, we're not sharing it with you. And we had to go to the minister and ask him to send a memo, and he did, and so then they started giving us the data. But the problem still is their reluctance to give us data could also lead to their reluctance to give us complete data. So we may or may not have gotten everything that we want. As far as the application itself goes, you can have it anytime. My information, I'm not sure how my information is distributed, but if you send me an email, I can give you probably a 2-day orientation to how to set it up, configure it, and use it. And it's constantly being updated, and I get the updates all free. And it's updated in such a way that you can customize the forms, put your hospital logo at the top, whatever you want. It's in Gregorian. NHSN is all Gregorian, but built right onto the form is a Hijri to Gregorian converter. So this is all, like I say, built into the form. I think I've overstayed my welcome here.
Yeah. Now it's the time for the first break. It's from 10:30 until 11 o'clock, where we will start the second lecture. The break there is a coffee and slight snacks. It's downstairs, ground floor, next to the doctor.